This conference will now be recorded.
Okay. Okay, it sounds like everybody, we may be at our number. Good morning, everyone. I'm Andy Ellen, President General Counsel of the North Carolina Retail Merchants Association, and wanted, along with Mike James, I'll turn it over to Mike in just a second, welcome everybody to this North Carolina Medicaid Managed Care Pharmacy Summit, a rollout of the tailored plans. And what a great turnout this morning, early on a Wednesday morning, so at 8 a.m. Just a couple quick reminders of this. One, there's going to be a chat bar on the right-hand side. Put your questions in there. We will take questions at the very end of this. Second, you should be on mute. Angela's got an ability to mute everybody on this call. So you'll have to physically unmute yourself by using the turning off the mute button in your area. There's also should be in the bottom left corner an ability to raise your hand if you have questions. But again, we're going to take questions at the end. Please feel free to put your questions in the chat box that's in the top right corner. But again, on behalf of our members, we really appreciate Angela and all the panelists for being on here, and want to say thank you for everybody for taking time out of your day on this very important issue, and we appreciate your attendance. And with that, I'll turn it over to Mike James. Mike, are you able to unmute yourself? Okay. Okay, Mike's having a little bit of problem technology wise. So Mike James is with the Association of Community Pharmacists that helped us put this together as well. And I'll work on Mike on the side in a minute. So with that, Angela, we were going to turn it over to you for opening remarks. We're, I think, just 1 minute behind on that. So.
Okay, thank you. Angel, if you would please advance the slides to the agenda. There we go. So the purpose of today's webinar is to provide important information to you about the upcoming launch of the tailored plans as North Carolina Medicaid continues to transform our traditional Medicaid system over to managed care. We're going to provide you with some important information about each of the contracted tailored plans today and provide an opportunity for pharmacists to ask questions about what to expect, our operational changes, and our processes. I'm going to speak first, and then the directors of pharmacy are all going to get to introduce themselves to you. And then the meat of our presentation today will be a town hall question session, followed by some Q&A by the audience. So let's go ahead and get started. Okay, if we'll go to the next slide for me, please. All right. So good morning. My name is Angela Smith, and those of you that have not met me, I serve as the Director of Pharmacy and Ancillary Services for North Carolina Medicaid. Thank you again for taking the time to attend our webinar this morning. It's exciting to see what good attendance we have this morning. It looks like we're already up to 230 people, and that's exciting. We appreciate you and all that you do day in and day out to serve North Carolinians who need you the most. We know you have a busy day ahead of you, so we're going to do our best to get you out of here by 9:30. Before we begin, I want to take just a few minutes to center us around our North Carolina vision for managed care, and then we'll get into the updates. Hopefully by the conclusion of this, you'll have a better understanding of how the new tailored plans fit into this vision. So here we go. The vision is to improve the health of North Carolinians through an innovative, whole person centered, and well coordinated system of care that addresses both the medical and non medical drivers of health. Okay. So there are currently around 2.8 million Medicaid beneficiaries in North Carolina. And of those, around 1.78 million are in the standard plans, which launched last July. And after the tailored plans launch, we're expected to have about 875,000 members in Medicaid Direct and 150,000 in the new tailored plans. So our focus today is on the new tailored plans. Okay. So on September 29th, if we can go to the next slide, the state announced that the tailored plans would launch on April 1st of 2023. Now this includes both the medical and the pharmacy benefits to launch together. This means there will not be a lag for the pharmacy benefit to launch a few months after the medical benefit as we had originally planned. The entire plans will now launch on April the 1st. So this delay was carefully thought about, but it was deemed to be necessary to allow the plans more time to contract with additional providers and to validate that the data systems were working properly. So really felt this would be best for our members. So with the exception of tailored care management and the 1915I option, which is awaiting CMS approval, the launch dates have been moved to April the 1st. Okay, so we're working really hard to share this updated information through webinars, the website, and fact sheet. We want to make sure our members and providers have the most current information. And again, this was just announced on the 29th. Okay, so what does this mean for our members? Well, they have a new choice period. The new choice period will be held in mid-January. This will give members a chance to choose their primary care provider. Now, if a member has already chosen a primary care provider, the plan will of course keep the record of their choice, and members can continue to contact their plan to choose their primary care provider. The new plan start date gives the plans more time to add primary care providers to their network, which of course gives the members more choice in January. So that choice period includes the opportunity for members to change any provider choice that they may have made before the 1st. And at the end of the choice period, if a member has not selected a primary care provider, then they are auto-assigned a provider. And we'll share the new choice period and end date once all of this is finalized. After auto assignment, the members will still have the opportunity to change their assigned primary care provider if they need to. So what does this mean for pharmacy? Not much really, because we were already poised for an April 1st launch date. So for us, that has really stayed the same. Okay, next slide, please. Right. So the tailored plans will provide the same services as the standard plans, as well as some additional specialized services for individuals with significant mental health and substance use disorders, intellectual and developmental disabilities, traumatic brain injury, people on innovation waivers, as well as people using state-funded services. Federally recognized tribal members and individuals who qualify for those services through the Indian Health Services are also allowed to opt in to the tailored plan. There are 6 tailored plans with 1 tailored plan assigned to each county. And they're listed on the slide here for you. They include Alliance Health, East Point, Partners Health Management, the Sandhill Center, Trillium Health Resources, and Via Health. Beneficiaries will be enrolled in the tailored plan that serves their administrative county. So that's the county that manages the member's Medicaid case. That's going to determine which tailored plan the beneficiary will be auto-enrolled in. There's only 1 tailored plan per county, and beneficiaries cannot choose a different tailored plan. The next slide, Medicaid Direct. Now remember, Medicaid Direct is our traditional fee-for-service program, and we'll continue to serve members who are not enrolled in the standard plans, the tribal option, or the tailored plans. And this includes dually eligible members who have Medicare and Medicaid, foster children, family planning, the medically needy, and our refugee programs. And of course, we still have the traditional LME MCO services, which will be available for Medicaid direct patients provided through CCNC and the LME MCOs. Next slide, please. I'd like to take just a few minutes to refresh you on how the pharmacy benefit works within managed care. The pharmacy benefit is what we call carved in to managed care, which means the plans will each provide and pay for pharmacy services. Some states have opted to carve out pharmacy. If you're not on mute, please go on mute. Actually, I can probably try to mute everyone. Okay. All right, sorry for that. Some states have opted to carve out pharmacy, but North Carolina has carved in pharmacy. And for this to be successful, the North Carolina law mandates that the health plans use the same drug formulary as established by the department. As you may know, Medicaid operates under an open formulary with utilization of a preferred drug list. Now, the preferred drug list includes medications which the state has deemed to provide a financial advantage to the state as compared to similar medications within a class. The PDL is a tool that's utilized by the state to drive utilization towards these preferred medications. So medications on the PDL, as you know, are divided into preferred and non-preferred. The non-preferred medications generally require trial and failure of one or two of the preferred medications before the non-preferred medication will be covered. The PDL is not a comprehensive list of all the medications covered by Medicaid. The PDL in itself does not define the Medicaid drug formulary. It's only a tool we use to drive utilization of some of the drug classes. All medications not listed on the PDL, which are eligible for federal rebate, are covered by Medicaid. Thus, we have an open formulary in conjunction with a preferred drug list. So the plans by law will be using the same single state PDL. After year one, the plans will be allowed to suggest changes to medications on the PDL and to clinical criteria and coverage policies. Those requests will be vetted by the department and carried through the same approval processes that are in place today. So only if the department approves will changes move forward, and all changes that are made will be applied to that single state PDL. So all the plans, the standard plans, the tailored plans, and Medicaid Direct will be operating within the same common formulary. Go to the next slide. This slide just reiterates that concept of the single state PDL. All the plans follow the single PDL and existing fee-for-service or Medicaid direct policies and clinical criteria. The approval processes for change are the same. Any changes made will be applied to the single PDL and implemented across all plans and fee-for-service. Next slide. Okay, so what should you expect after we launch tailored plans on April 1st? Okay. Pharmacy should expect timely reimbursement from the plans. There are penalties built into the contract if providers are not paid, so hopefully this will provide you some confidence that you will indeed be paid for serving our members. The plans provide payment within 14 days. The professional dispensing fees are paid at a flat rate of $10.24. Drugs are reimbursed using the same logic as Medicaid Direct. So the plans, they'll continue to pay the mail and delivery fees, and there will be no PBM transaction fees. 340B claims will be processed the same as they are today in the fee-for-service program. And at launch, the plans will honor prior authorizations for the life of the PA. So the PAs will transfer to the Taylor plans, and they'll be honored until the end of the PA. Now, if any issues arise at launch, such as a PA not showing on record when it should, the plans are expected to exercise flexibilities when it's clinically appropriate. Our goal is, of course, for the member to get their medications on day one with no interruption. It is important to note, substance use disorder PAs will not transfer to the plans. And this is due to the fact that information regarding the treatment of substance use disorder cannot be transferred or shared under federal law without member consent. So for this reason, historical PA for drugs used to treat substance use disorder are not able to be sent to the PHPs during the transition of care. So members that are on non-preferred substance use disorder medications which require PA will need a new PA for their prescriptions to process. This will require the provider to write a new PA. For these instances, please, please, please remember the option to use the 72-hour emergency fill and override for these drugs. Remember, our goal is to ensure our members have access to medications without interruption. This next slide is a reminder about the 72-hour emergency supply override. As North Carolina Medicaid providers, pharmacists are asked to please become familiar with the override codes and to utilize them appropriately when administering the Medicaid benefit. This override is available anytime. It's not just for the launch of the Taylor plans. Okay. So day one, our primary goal for day one at Medicaid is to ensure that our members receive the care and services they need, which includes their medications. So when they arrive at your pharmacy, we want them to have a seamless experience as they transition over to their new Taylor plan. And we can't do this without your help. Okay. So there are several mitigation strategies that have been put in place to support you and the members during this time. For example, we expect you to use the 72-hour emergency fills in the event a PA is not ready. The NC Tracks portal will include information on coverage and will likely be your best source of truth on coverage. A rejection message will be returned to the pharmacist from NC Tracks upon prescription entry, and that message will tell you what plan the member has been assigned to and the new BIN number. We found that to be very helpful last July with the standard plan launch, and we expect it'll be just as helpful in April. You'll be able to contact the plans directly. In fact, we will be providing you contact information today, so you'll have that. When it gets closer to April 1st, DHHS and the plans will be distributing and posting help sheets, which will include the BIN, PCN group numbers, and contact numbers. So the plans, as well as Medicaid, will be operating command centers to triage issues as they arise so that we can resolve issues as efficiently as possible. DHB will be sending each plan 2 years or 24 months of historical pharmacy claims data and PA for its members. So they will have that information accessible to them on day one. Now, the Taylor plans, they're required to honor existing and active pharmacy PA on file within Medicaid or Health Choice or any other health plan through the expiration date of the active service authorization. Then additionally, for a period after the launch, PHPs will be required to pay claims and authorize services for Medicaid eligible non-participating or out-of-network providers equal to that of in-network providers. The next slide. Just as a reminder, we are working to update the information and the resources to reflect the new launch date of April 1st. This slide includes several places that members can go to for more information. And for providers, go to the next slide, we also encourage you to continue to take advantage of the resources here, particularly our provider playbook. The playbook has numerous resources, including a fact sheet on contracting with the Taylor plans. Okay, at this point, let's turn the floor over to our directors of pharmacy for the tailored plans to introduce themselves to you. Okay, let's start with you, Neil. Would you like to go ahead and kick us off here by introducing yourself and telling us what plan you represent?
Sure, Angela. Good morning. My name is Neil Roberts. I'm the Director of Pharmacy at Alliance Health Plans. I'm grateful for the opportunity to participate in this session this morning and share a little bit of information about our tailored plan. So I was hired by Alliance just over a year ago to oversee the implementation of the plan's outpatient pharmacy benefit, but I've been employed as a pharmacist in North Carolina for over 30 years in a variety of practice settings, including 10 years in managed care that included working directly with North Carolina Medicaid members, community pharmacies, and primary care providers to improve health outcomes. And with me today, I'd also like to introduce Vera Reinstein. She's Alliance Health's clinical pharmacist who will be joining me today during the Q&A session, and she'll be sharing some important information about behavioral health pharmacotherapy related for community pharmacists. Thank you.
Good morning. I'm Tracy Snowden Muller, and I'm the Director of Pharmacy at East Point. I joined East Point about a year ago, and I have a background in hospital, retail, institutional, closed-door pharmacies, including behavioral health and infusion. I came to North Carolina about 8 years ago, but have been a pharmacist for over 30 years. And I came to North Carolina from a Western Mass healthcare network. I look forward to working with all of you in the future.
Good morning. My name is Karen Cease, and I'm the Pharmacy Director at Partners Health Management. I'm happy to be here with you all this morning in this important discussion. I joined Partners Health Management earlier this year. I've been a pharmacist for 20 years in a variety of settings to include hospital, home infusion, managed care, and then community retail in both the corporate and independent settings. We're excited to work with everyone at Partners to make sure that our members and beneficiaries have what they need. And thank you for your time today.
Good morning, everyone. I'm Richard Peters. I'm the Pharmacy Director for Sandhill Center in Western Central North Carolina. I've been a pharmacist in North Carolina for over 25 years, and 20 of those I was the owner and CEO of an independent pharmacy. I was thrilled a little over a year ago to be hired by Sandhill Center to help with the implementation of the pharmacy benefits for tailored plan, and I look forward to working with everyone and serving the Medicaid members of North Carolina. Thank you.
Good morning, everyone. My name is Jason Swartz. I'm the Pharmacy Director for Trillium Health Resources, and we operate on the eastern coast of North Carolina, the eastern counties. Prior to coming to Trillium, I was with Otsuka Pharmaceuticals for a little while, and then prior to that, I was the Pharmacy Operations Manager for North Carolina Medicaid Pharmacy Program.
Good morning, everybody. My name is Jay Vora. I'm the Pharmacy Director for VIA. So I've been with VIA for a little over a year to implement the tailored plan program. Prior to VIA, I worked for UNC Health in ambulatory care and pharmacy benefits. And before that, had some experience in community pharmacy, both with Car Drug as well as an independent in Durham. Look forward to working with y'all.
Okay. Um, Andy, did you want to jump in here? All right, maybe not. Well,
I'll be glad to. I apologize,
okay.
Angela. Yeah, I'll be glad to. And we've got a really good group of folks, as you see on here. And again, we are encouraging people as we move to the next piece of this to make sure that you put your questions in the chat area. And I also meant to say earlier, and I apologize, Angela, that if you weren't talking, to maybe turn your screen off to help with the transmission of the information. But Angela, did I miss anything else on what we were talking through?
No, I think that covers it. And we're getting ready to move into our town hall questions and answer section. I believe that lots of these questions came from you and Mike, right? From the field.
Yes, Angela, my apologies on that. One of the things that Mike James and I try and do is for the department is instead of them getting overwhelmed by individual questions, is try and accumulate those questions together and provide them to the department so that they can answer them and help on their own manpower of having instead of having to answer the same question from 15, 25 different people so you can get one consistent answer. And so many of these questions that you see were ones that Mike James and I had received from Mike from Independent pharmacists primarily, me from the chains, and had provided to Angela previously as a way to try and get all the information we could out. And I think they've got a very good set of questions and answers that should provide a lot of information to answer, I think, every question, hopefully every question everybody has, although there's no bad question going forward. So.
Absolutely, absolutely. Thank you, Andy. At this time, let's ask John Matta to lead us in our town hall questions and answer session. For those of you who have not met John, he joined us in July as our pharmacy operations manager. He comes to us from Walgreens, where he has over 20 years of experience. All right, John, we'll turn it over to you.
Thank you, Angela. And you see the slide with this first question. Great. Okay, our first question is, what is the timeline for the rollout of managed care tailored plans for North Carolina?
I'll take that question, John. So the tailored plans will go live on April 1st, as we talked about earlier, and this includes both the medical and the pharmacy benefit. Both of those begin April 1st. Now that delayed start is going to allow our tailored plans more time to contract with additional providers, and this will only support member choice, and it gives us more time to validate that the data systems are working appropriately. We had previously communicated that the pharmacy benefit would be delayed and would go live April 1, and the rest of the benefit, which included the medical claims, DME, and the medical drug claims, were to go live on December 1. So the change is that the part that was to go live in December is now moved to align with the pharmacy benefit going live on April 1. Okay, so you might hear that there are still some services that go live on December 1, but those services, they're really not pharmacy related. And those are the tailored care management and the 1915I option that I spoke about earlier.
Thank you, Angela. Next question, please. With the delay of the tailored plan launch to April 1st, will this change the pharmacy provider and tailored plan contracting timeline?
Let me jump in there too. John, no, the change does not impact our contracting timeline. The tailored plans are encouraged to proceed with enrolling pharmacies into their networks now.
Yeah, Angela, this is Neil again. It'd be best for pharmacies to contract with all the tailored plans, not just the one in your county, in case our members utilize a cross-county pharmacy. In fact, our PBM, Navitus Health Solutions, is contracted with Alliance Health Plan, hopes to have approximately 2,300 pharmacies statewide in its Medicaid managed care network to ensure network coverage for our members who may need a prescription filled while they're traveling or while they're seeing a specialist in another region.
Hi, this is Tracy. I just would like to emphasize the recommendation that pharmacies not wait to execute their contracts associated with the tailored plan PBMs. In fact, please do not wait until March of 2023 due to the need in processing time that it will take to set up your new contract. We all want our members to have a smooth transition to tailored plan without any disruptions in their current provider of service, which includes pharmacies they use.
And also, this is Karin from Partners. Definitely want to add that it's really important to remember that the payment will continue across all plans. As Angela referred to earlier, there will not be any differences in any of our contracts regarding your reimbursement. And we are, once again, contractually required to use the same reimbursement logic as Medicaid Direct.
Thank you, everyone, for your responses. Our next question: what does it mean to be a standard plan versus a tailored plan versus Medicaid Direct?
I'll take that one. So, North Carolina Medicaid Managed Care is the term that we use to identify the new Medicaid program overall. Okay. And then managed care is provided by what we refer to as the health plans or the PHPs or just the plans. Members have one plan for most of their health services, and that includes physical health, behavioral health, pharmacy, and addressing any of their unmet health-related resource needs. So we now have 4 types of health plans. Those are Medicaid Direct, standard plans, the tailored plans, and the tribal option. So Medicaid Direct is our traditional fee-for-service program. It provides many of the same services as the health plans. People who do not get their services through a health plan will continue to receive their coverage through Medicaid Direct. The standard plans, there are 5 of them, and they went live in last July, 2021. They provide integrated physical health, behavioral health, pharmacy, and long-term services and support, as well as programs and services that address other unmet health-related resource needs. You know them as Healthy Blue, Carolina Complete, WellCare, AmeriHealth, and United Healthcare. The majority of our members are in the standard plans. The Eastern Band of Cherokee Indians tribal option is available to tribal members and their families, and it's managed by the Cherokee Indian Hospital Authority. And then lastly, the behavioral health and IDD tailored plans, which is what we're talking about today, they provide the same services as the standard plans, plus some specialized services for individuals with significant behavioral health conditions, intellectual and developmental disabilities, traumatic brain injury, and people that are using state-funded and waiver services. And if you'll go to the next slide, this is a map showing the tailored plans and which counties they serve. So the members are enrolled in the tailored plan that serves their administrative county. So I'll say again, this is the county that manages the member's Medicaid case. That determines which plan they're auto-enrolled in. So there's only one tailored plan per county, and members cannot choose a different tailored plan. There's 6 tailored plans, including East Point, Trillium, Via, Sandhills, Partners, and Alliance. If you'll go to the next slide, we've got each plan listed, starting with Medicaid Direct over on the left. If you look over to the right, you'll see each tailored plan listed and their corresponding PBM and their standard plan partner. Each tailored plan uses their standard plan partner for different things. So it's really best to consider that tailored plan as a totally separate entity from their standard plan partner. You might think of that standard plan partner as serving in more of a supportive role. And I'll just note lastly that each tailored plan will have their own member card. And this member card will include their Medicaid ID number and also the tailored plan's own distinct BIN and PCN number.
Thank you, Angela, for that great response. The next question: please explain the roles of your tailored plan versus your PBM when it comes to contracts and interactions with pharmacists and pharmacies.
Hey, this is Rich from Sandhill Center. I just wanted to tell you guys that Sandhills is contracted by the department to manage and ensure that pharmacy benefits follow all Medicaid rules and requirements. We will be administering the pharmacy benefits by subcontracting with PerformRx, a PBM, to provide adjudication for those benefits in accordance with the guidelines. We have complete oversight to ensure compliance, and PerformRx will provide us with regular reports demonstrating the ongoing adherence of required standards. I believe most pharmacies are already processing under some or maybe all available contracts through PerformRx, especially if your pharmacy is a chain or independent member of a PSAO like Epic Pharmacy Network. Every pharmacy that is listed on Medicaid's provider enrollment file would have already received an offer to contract with each tailored plan network. If you have any questions on your contracting status, you may call PerformRx directly, and pharmacies serving our 11 counties are welcome to reach out to me for specific tailored plan questions or PBM concerns.
This is Jason from Trillium Health Resources. I'd also like to add that our tailored plans will operate very much like the standard plans in the state, as well as Medicaid Direct, with regards to pharmacies and pharmacists. Our PBMs have, as Richard stated, should have already contacted you with regards to contracts, and you will interact with them directly with regards to those contracts. When you have an issue with the claim, like you do today, you will call the PBM for assistance, just as you would for the other standard plans or for the state when you call NC-TRACS. Now, I do want to emphasize that the PBM is our contractor. So if you have an issue with the PBM, we would love for you to call us directly at the plan to address your concern.
Hey, this is Jay with VIA. Like the others have mentioned, Navitus will hold the contracts for VIA with the individual pharmacies and certainly be there to support pharmacies and providers in getting access to medications for their patients. So any outpatient pharmacies should work with Navitus directly on any questions regarding contracting. I did want to mention, though, if you're a DME provider, those DME contracts are held by the health plans themselves. So you would want to contract with VIA directly for DME. And then I guess to the point of sort of our role as the director with the PBMs, my role is really to watch over the PBM, like Jason and Rich have mentioned. Our goal is to make sure they're following all the rules and serve as that point of contact to resolve any grievances.
Thank you, Jay. So is it accurate that pharmacies enrolled in Medicaid should have already received a contract from your PBMs if they are not yet contracted with your respective PBMs? And if not, who should they contact?
This is Jason again from Trillium, and yes, it is accurate. The pharmacies enrolled in Medicaid should have already received a contract from our PBMs. The contact numbers for our PBMs and for the tailored plans will be listed in the slide deck and will be distributed after the meeting. Now, we encourage you to please reach out to the PBMs or to the tailored plans to verify your contract status if you don't know, or to get an update. But please don't wait to sign those contracts, as we stated earlier. The process can be timely, and we really want everyone signed up before April 1st, before go live.
Thank you, Jason.
Mm-hmm.
The next question we have, who gets to transition to tailored plan? Is it optional? Are members allowed to remain in a standard plan or Medicaid Direct if that is their preference?
Yeah, this is Neil again from Alliance. I'll take that one. So tailored plan eligibility can be based either on diagnosis like schizophrenia or what services a person is receiving like an ACT team. Generally, a tailored plan eligible member has a significant mental health disorder, a substance use disorder, intellectual developmental disability, or a traumatic brain injury. Approximately 5% of all Medicaid beneficiaries will be enrolled in tailored plan, and tailored plan enrollment is based upon the member's county of residence. Therefore, members are not permitted to enroll in a different tailored plan unless they move to a county that's within that plan's catchment area. Medicaid eligible members may choose to remain in the standard plan, but should be aware that some specialty mental health and IDD services are not provided by these standard plans. So members remaining in Medicaid Direct who will not transition to a tailored plan or standard plan are those who are either dually eligible with Medicare and Medicaid, are medically needy, or are enrolled in the Community Alternatives or CAP program, the Health Insurance Premium Payment Program, or in the foster care program.
Thank you, Neil, for that response. Our next question. Will North Carolina Department of Health and Human Services still be serving some Medicaid recipients?
See, Angela, I'll take that one. Yes, we will be, and that is through the Medicaid Direct plan. If you'll go to the next slide, have a pie chart here for you. If you look at the one on the left, this represents the Medicaid Direct population. So Medicaid Direct will continue to serve the dually eligibles, the foster care members, transitions to community living, some waiver programs, and then some limited benefit populations such as family planning. Medicaid will continue to serve around 875,000 members. And as you can see here in the pie graph on the right, the tailored plans are expected to serve around 150,000, and then the majority of our members are in the standard plans.
Thank you, Angela, for that response. Next question, please. What happens if my patient comes without a card? How do we verify which plan the patient is on?
Hi, this is Tracy from East Point. I'll take that question. Pharmacies will be able to verify member enrollment to the tailored plan MCO Medicaid program through NC Tracks, as Angela explained previously, through the NC Tracks portal, similar as they can do today. Also, when a claim is sent through NC Tracks, a message will return indicating which plan the member is enrolled in, as well as the BIN number.
Thank you, Tracy. In addition to leveraging the NC Tracks portal to confirm tailored plan enrollment, providers may also search beneficiary information 1 month in the future, so they can look in April to see what the status will be starting in May. And we're going to put the link now in the chat so you can access it. Okay, thank you. The next question, what if my patient is here for a refill and now they are on a new plan? Do they need a new prior authorization for the new plan?
Hi there, this is Karen from Partners again. I'll answer that question. So the Behavioral Health IDD Tailored Plan must honor the existing and active prior authorizations that are currently on file with the NC Medicaid Direct LME MCOs or the standard plans for the life of the prior authorization. We're doing this to make sure that we ensure continuity of care for members, and we also want to minimize provider burden. A new prior authorization for the new tailored plan is not required to replace an existing or active PA for drugs. Now, there is one exception to this that is for substance use disorder medications, which will require a PA, as Angela mentioned previously, due to regulatory requirements. So remember, the prior authorization will not transfer from Medicaid Direct to the tailored plans for these medications.
Thank you, Karen. Our next question. Will the tailored plans utilize a 72-hour fill, same as Medicaid Direct would, in the event an issue arises with PA at launch?
Hey, this is Rich from Sandhills again. Pharmacies will also be able to use a 72-hour emergency fill if necessary, and certainly all pharmacies are encouraged to do so should the need arise. We would never want to jeopardize a patient's access to medications or cause an interruption of therapy. If you have issues you cannot resolve, do not hesitate to contact the corresponding PBM. We have instructed Performer X to do everything possible to ensure there are no gaps in care.
Thank you, Richard, for that great response. Can I get the next question, please? Will all the prior authorization processes be universal, or will they vary amongst tailored plans?
This is Jason. All prior authorization rules and requirements will be the same across all of North Carolina Medicaid. That's for the tailored plans, the standard plans, and even Medicaid Direct. Now, the processes may differ between plans, but all will have call centers you can call to inquire about a particular prior authorization, or if you have any questions, or for the provider to call in a prior authorization. In addition, for fax requests, all PA forms should be the same with regards to questions asked and required information needed. Now, each tailored plan website will have access to these prior authorization forms and links to their PBMs websites also.
Yeah, like Jason mentioned, certainly all of that applies to Via's PBM now, but they'll be processing those prior authorizations for us, and we'll have access or links to those forms on the Via website several weeks before go live. I did want to emphasize, though, it's important that prescribers are filling out the form specific to that plan, even though the questions or the requirements are going to be the same across all the plans. And really, that's just going to help make sure that they're getting that form back to the right PBM so it's processed for that member appropriately. Also, I know a lot of folks like to use Cover My Meds, and certainly that's always an option. But it's important to note that they don't always have the most up-to-date forms. The best option to avoid any frustration or duplicate work is to make sure that you're referring providers to that plan's website where they can get the most up-to-date form.
Thank you, Jason and Jay. Can we get our next question, please? Will the new tailored plans follow the single state preferred drug list? Will the same committee structure and approval process continue?
I'll take this one. Yes, I spoke about this earlier, but it's certainly worth mentioning again because this is our #1 question from providers and stakeholders in the community. All plans follow the North Carolina single PDL in conjunction with an open formulary of covered drugs. So all drugs that are enrolled in the Medicaid drug rebate program are considered covered by Medicaid, and some of those covered drugs are also managed through the PDL. Remember that PDL is a tool that's used by Medicaid to drive utilization towards those covered medications, which are the most cost effective to the state. So the PDL approval process remains the same. After year 1, the plans may suggest recommendations for change to the PDL, but all recommendations then go through the same consideration and approval process already established by the state. And that includes review by the Pharmacy and Therapeutics Committee, and then the Physicians Advisory Group, followed by a public comment period. And then any changes that are ultimately approved by the state will be made to the single PDL and implemented across all plans.
Thank you, Angela, for that great response. Can we get our next question, please? Will the cardholder IDs be in a unique or different format than existing MCO cardholder IDs?
This is Karen again from Partners. I'll gladly answer that. So the state Medicaid ID assigned to the individual is used for any and all cards, Medicaid Direct, standard plans, and tailored plans alike. All cards, regardless of who's responsible for it, uses the Medicaid ID that's referred to on their Medicaid card. Each tailored plan will have their own card, and the format may appear a little different than the standard plan cards or the state card, but all the information will be listed on there with the Medicaid ID. Thank you.
Thank you, Karen. Next question, please. Medicaid has been the payer with the best reimbursement in our state for many years. and we understand reimbursement will not change under any of the managed care plans. Is this also true for the tailored plans? What can pharmacists expect regarding reimbursement as we move forward with the new tailored plans?
John, that's a great question. And the dispensing fee and pharmacy claim reimbursement logic is set by the tailored plan contract, legislation, and the state plan. And there will be no difference in how the tailored plans reimburse pharmacies for drug costs, nor the dispensing fee as compared to Medicaid direct. It is important that the dispensing fee and drug reimbursement logic continue unchanged, not only to remain fair to pharmacies, but to encourage continued participation in the evolving North Carolina Medicaid programs, preserving access to medications for our members across all pharmacy settings. As a result of continued dispensing fee discussions, a proposal to remove the limit of one dispensing fee per member per medication per month is being considered with a high probability of success. This is especially positive, for example, with medications that are often dispensed weekly, such as Suboxone or Clozapine, where in the past pharmacies may have only received one dispensing fee in every 4 fills. Again, this is intended not only to be fair to pharmacies, but encourage participation in these programs to benefit our members, since access is one of our highest priorities.
Thank you, Richard, for addressing this question. Our next question. We have heard that managed care will be done differently here in North Carolina versus other states. Are tailored plans unique to North Carolina? How will tailored plans bring value?
This is Jason from Trillium. I'll start off by saying that Medicare in any given state is unique to that state. Thus, the managed care in a given state is unique to that state. Now, in North Carolina, we are unique in that it has created separate plans for the general Medicaid population, which are in our standard plans, and our severely mental ill population, which will be part of our tailored plans. Now, MCOs in general have more opportunities to bring value to Medicaid program by being able to provide unique clinical programs and services to the Medicaid population. Tailored plans hope to do the same, and for the first time be able to coordinate care for our severely mental ill patients in a much more efficient manner, because we will be taking care of all of their healthcare needs. In the past, severely mental ill patients had fragmented care between the LME MCOs and the state. Now, all of their care, their behavioral health, their physical health, and their pharmacy care will be under one plan.
Thank you, Jason, for clarifying that question for us. Our next question. We know that state Medicaid will continue to aggregate buy through the rebate vendor, which means that tailored plans will not receive any revenue from rebates. Pharmacists worry that this will result in PBMs using different clawback practices. How can we prevent this non-transparent retroactive fee assessment from happening in our state?
Hey, this is Jay, and that's a really great question in an area where I think North Carolina Medicaid has really attempted to protect pharmacies and adhere to industry best practices. So the department's contract with each tailored plan is really explicit in that it says that we have to follow the department's reimbursement and recoupment practices, the exact same as Medicaid direct. So there's no DIR fees, there's no clawbacks allowed. No transaction fees, and that's all built in with our contract. So there's really none of that you should see in any of the Medicaid tailored plans.
Thank you, Jay, for clarifying that for us. The next question. Keeping independent community pharmacies viable obviously makes sense regarding access to medication. However, what are your thoughts on why community pharmacies must remain open?
I think I speak for
Tracy, we're having trouble hearing you.
Hi, it's Tracy. I apologize for that. I think I speak for all the other directors of pharmacy that we see that it's important to all the tailored plans that we contract with as many independent community pharmacies as possible. And there's several reasons for that. We recognize the independent community pharmacies have high patient satisfaction. And due to that high level of service and development of strong patient relationships they are providing, that results in better outcomes for our members and their patients. We recognize that independent community pharmacies often provide more services and conveniences to their patients, such as compliance packaging, offering immunizations and LAI administration, or DME supplies, making more services available to their members at the same location. So we find it to be highly important that we contract with as many community pharmacies as we can.
Thank you, Tracy, for that great response. The next question we have: what clinical services, public health initiatives, or chronic disease states do you envision your tailored plan will be interested in paying pharmacists to help manage?
Hi, this is Vera Reinstein, clinical pharmacist with Alliance. And building on what Tracy just mentioned, I'll start with those services that Medicaid has recently begun paying pharmacists to do, which are really important. For our tailored plan, SPMI, or serious persistent mental illness population, including schizophrenia and bipolar, long-acting injectable antipsychotics have demonstrated improved outcomes that we want for our members, and pharmacy being able to administer these LAIs not only offers convenience to the member, it also improves access, which is very important, and also reduces waste. And as you're aware, for the past year, Medicaid has been reimbursing pharmacies for administration of LAIs. Extending a COVID flexibility of mailing and delivery of medication, that is also covered. And most importantly, also with our behavioral health population, many smoke, and most of those who do smoke or use tobacco products do want to quit and can quit with the proper support. Because of this, Medicaid recently instituted a standing order for pharmacists to prescribe nicotine replacement therapy, which helps support Medicaid actually covering this OTC product. The next step, which tailored plans are advocating for, is for Medicaid to cover pharmacists being able to bill for smoking cessation counseling to go along with the ability that you already have to prescribe nicotine replacement therapy products. This would tie in very nicely also with referrals to the NC Quit line for behavioral support. And also pharmacists are in a great position to advocate for patients or directly to their providers for varenicline or bupropion, to help support their tobacco cessation efforts and to stay quit. Now I'd like to move to some more pharmacy services we think would provide value to our members. Payment for these additional services are contingent on Medicaid approval and funding, but these discussions are underway. First, adherence packaging and medication synchronization are services that some pharmacies, especially some of the independents, already offer and are very helpful for our members with their cognitive impairment that is a long-term consequence of schizophrenia. In addition, for our members with limited incomes, 90-day supplies reduce copay burdens and can help improve medication compliance. Clozapine is the only antipsychotic for treatment-resistant schizophrenia that's having tried and failed 2 adequate antipsychotic trials. Pharmacy support for clozapine through the clozapine REMS registration and stocking clozapine is essential. There's actually a ANC, absolute neutrophil count, point of care test that can be done in the pharmacy, and it would be really helpful for this to be available. Another point of care testing opportunity besides ANCs for clozapine is the Annual metabolic monitoring of lipids and glucose, that's really required with all second generation antipsychotics. This is a HEDIS measure, a quality measure. And point of care testing reimbursement is a potential future opportunity as well. Pharmacies can provide many services also to support substance use disorders, prevention and treatment. For some of you that may have already taken North Carolina Association of Pharmacists or NCAP training on SBIRT, which is screening, brief intervention, and referral to treatment. In the realm of opioid safety, we really depend on pharmacies to counsel patients on safe opioid use, safe storage, and disposal, and also recommend naloxone under the standing order for those on higher morphine milligram equivalents or MMEs and or those with significant risk factors. Pharmacies can also create pain contracts with patients. For those patients who actually have opioid use disorder, medications for the opioid use disorder is the highest evidence-based treatment that helps prevent overdose deaths and has the highest recovery rate. Pharmacy access to buprenorphine, of course now in the sublingual or transmucosal product, and potentially the long-acting injectable version as well, including administration, is critical, as is having access in the pharmacy to injectable naltrexone administration. Harm reduction is often the entry point to treatment for those who are still in active use to get them in the path towards recovery. Pharmacists being proactive in dispensing naloxone via the standing order is critical. The pharmacy should also be a safe place for syringe purposes without a prescription and no questions asked. But just to clarify, for Medicaid to cover syringes, a prescription is still needed. Making the entire pharmacy a no judgment, stigma-free zone will support those with substance use disorders towards recovery. That includes pharmacists and technicians, everybody that's going to interact with our members. With all the focus on opioid use disorders, of course, we know other substance use disorders are continuing to be a concern. Illicit substances are all expected these days to have some sort of fentanyl analog. So all illicit drug users should have access to naloxone, and pharmacy can be an important access point. Alcohol and tobacco remain a huge concern in the Taylor Plan population. I talked earlier about the tobacco piece. Alcohol use disorder treatment includes medication-assisted treatments with numerous oral medications and also intramuscular naloxone, which of course pharmacy can now administer this. While the Taylor Plan population, of course, needs help with all these behavioral health conditions I mentioned, they actually still have physical health needs that often their mental health conditions interfere with their ability to take care of these needs. So continuing to have pharmacy support for diabetes, hypertension, asthma, COPD, contraception, etc., still remains important and something that we're considering. Thanks.
Thank you, Vera, for that very detailed response. Can we go to our next question, please? At Standard Plan launch, we had some issues with PA not crossing over to the Standard Plan, as it should have, and members not showing as enrolled in a plan when the member thinks they were, or when Medicaid Direct says they were. Having some of these data issues at launch are not expected. What have you done to learn from issues such as these, and how will this implementation be different?
This is Karen. I'll be happy to answer that. So it's important to understand and say out loud on here that we all recognize that with any large program change, implementations can have challenges. With that said, the Taylor plans are committed to working with the state and providers to get any issues resolved efficiently. And there have been lessons learned from the prepaid health plan standard plan launch of 2021. One topic we discussed earlier was around the prior authorizations and making sure that the prior authorization transfer to the new tailored plan at launch. happens to prevent any access issues and to stop from requiring providers to submit duplicate prior authorizations during this transition. So I just want to review, prior authorizations will be honored for the life of the prior authorization, regardless of whether they were initiated before the member was transferred to a tailored plan. If issues do arise regarding excuse me, regarding a member's prior authorization at launch, we'll be ready and able to ensure that members have access to that medication. Remember, our priority is to ensure that members have access to the care that they need. Thank you.
Thank you. Thank you, Karen. The standard plans shared lessons learned from the tailored plans, and among their list was the importance of having well-trained call center staff. A call center staff should be properly prepared to answer questions about eligibility, claim rejections, prior authorizations, and lock-in change requests from day one. With this launch, we are expecting that the call center scripts are prepared to address these issues and that staff are well trained on North Carolina Medicaid benefits. With that, I would like to go on to our next question. All right, our next question. The standard plans allow pharmacies to process point of sale vaccine claims, which is helpful. However, Medicaid Direct does not currently have this functionality. Will tailored plan members' vaccine require submission as a medical claim, or will they be able to process them at point of sale, similar to how we do it for standard plans?
I think we can all agree that processing vaccines at point of sale is the easiest and most integrated solution for all involved. And as such, Sandhill Center and PerformRx will be utilizing this method when pharmacy point of sale goes live on 4/1. Pharmacies will be able to utilize the point of sale system for vaccine processing through each tailored plan's PBM, or they may choose to send a medical claim directly to the tailored plan if they so desire. But I am guessing that most every pharmacy would prefer to use the point of sale, which will be available.
Thank you, Richard. Our next question. At standard plan launch, there were some pharmacies who were DME providers who had not contracted with the plans as DME providers. It then took some time to get them enrolled. Do you have any advice for pharmacies who also supply DME?
This is Jason again. Some points to consider for those of you who are also DME providers. First is that if you are an existing provider, you should have already been approached by the medical side of our tailored plans to be DME providers for us, because this was going to go into effect on December 1st. If you are contracted already, great, you're good. Otherwise, if you aren't and need one, you need to reach out to us as soon as possible to get that process started. You have time now because it's all been moved back to April 1st, but you do want to reach out to us. Now, there was a question in the chat stated that who specifically does a pharmacy need to contact to enroll as a DME provider for tailored plan members? At Trillium, our plan partner is handling those claims for us, but you will contact us directly to get that process started for contracting. We are providing that information for DME contracting for each of the tailored plans in the deck, which will be distributed later. A second thing to consider is that tailored plan managed care contract does not require that the 5 series of DME point of sale policies be followed exactly. However, the health plans are required to furnish covered benefits in an amount, duration, and scope no less than the amount, duration, and scope for the same services furnished to beneficiaries under any North Carolina Medicaid Direct. So we have to follow that, what Medicaid Direct does. Now, the contract allows the health plans to employ different prior authorizations and other criteria as part of their utilization management program, so long as they are evidence-based and provide a reasonable pathway to coverage. So you may see some differences between plans with regards to DME. Now, reimbursement for durable medical equipment, supplies, orthotics, prosthetics shall be set at 100% of the lesser of the supplier's usual and customary rate or the maximum allowable North Carolina Medicaid Direct rates for DME and supplies in accordance with Section 11 of Session Law 2020-88 as amended. So we have to follow those rules for payment. Finally, billing for DME is on the medical claims side, as I stated earlier, as it was with the state for all of DME. The only pharmacy point of sale DME exceptions are for glucose meters, strips, lancets, and therapeutic continuous glucose monitors, such as Dexcom G5, G6, and Freestyle Libre. Now, blood glucose testing supplies may be obtained by both the point of sale pharmacy side and through the DME program. Only non-therapeutic continuous glucose monitors may be provided by the DME side. So just points to consider.
Thank you, Jason, for that great response. Our next question. We understand some Taylor plans partner with pharmacies to provide non-emergency medical transportation, DEMT, for eligible members who need to pick up a prescription. Would one of the plans be able to speak to this benefit?
Hey, this is Jay with VIA. I think I can speak to that one. So certainly the tailored plans are doing several things to facilitate medication access. Like Angela mentioned earlier, all the tailored plans will be paying that $3 or $1.50 reimbursement for delivered medications or mailed prescriptions that is currently paid under Medicaid Direct. In addition, we will have the non-emergency medical transportation or NEMT rolling out with tailored plan launch. And so that's going to help arrange and pay for rides for members to doctor's appointments. A lot of the plans are going to extend that sort of required benefit to include trips to the pharmacies as sort of a value added service to their members. So all the plans will be a little bit different, but for the VIA counties, those trips can be scheduled a couple days in advance, and we'll cover transportation up to 50 miles one way to a pharmacy. There may be some opportunity for same day or a next day transportation, but that really sort of depends on whether the transportation providers are available. So it may vary by region. It's important that members should contact their member and recipient service line to get routed to the scheduler for NEMT. VIA is actually requiring that the member, or I guess their caregiver, is actually making that call versus a doctor's office or a pharmacy. And that's really just to make sure there's no miscommunication or missed rides, things like that. So a pharmacy could help the member call that member and recipient service line to get that ride set up, but the member really needs to be on the line to actually complete that appointment for transportation.
Thank you, Jay, for explaining that. Next slide, please. On these last two slides, we have included Taylor plan contact numbers, which may be helpful. Please notice there is contact information that should be used before April 1st and after the April 1st launch. This slide shows the numbers and web links that are active now. We have also listed the pharmacy directors and their emails on this slide. Can we go to the next slide, please? This slide is for post-tailored plan launch. On this slide, we have listed the BIN number and the PCN numbers for each plan, as well as the pharmacy and member line services. Can we go to the next slide, please? We want to take this moment to thank you all. This concludes our town hall question and answer section of our webinar. We can now address any questions from the chat that we may not have covered. Amy, are there any other questions in the chat we could address in the remaining time that we have together?
Yes, we do have some. I can read some of them if you would like. One question says, will there be specialty pharmacy accreditation through URAC, ACHC, etc., required through any plan to dispense specialty medications?
Would one of the plans take that question?
I can chime in on that one. So there is no accreditation required for specialty pharmacies, the same as with Medicaid Direct and the standard plans. So any pharmacy that has access to that drug, so certainly that's outside of like a REMS program or limited distribution, but if you have access to the drug, you can dispense that under Medicaid if it's covered.
And hey, I would just add that, that falls under the any willing provider clause. Certainly any pharmacy that would like to provide a specialty drug, if again, as Jay said, if they have access, then that's permitted. And the same goes with mail order. That kind of segues into that. While Sandhills has a pharmacy available for mail order, any pharmacy that wants to mail prescriptions is allowed under the any willing provider clause.
Okay, we have another one. I can probably answer this one. This is from the Duke Eye Center. They wanted to ask about the 72-hour override with eye drops. It's to give the patient 72 hours worth of medication. The packaging for eye drops does not allow for the flexibility for only giving 3 days worth of medication. What eye drops qualify for this type of override? For our 72-hour override in this situation, we would allow that bottle of eye drops. We would hope the pharmacy would use the smallest bottle if possible, but our 72-hour override would allow for that one bottle since it's not something that's a breakable package. Another question, is there a list of the PBMs that go with each health plan so we can know who to reach out to?
I'll take that. Yes, we have provided that in the slide deck, which we'll make available to you after the presentation. But those last two slides have contact information on it. And then there was a slide earlier on, you may recall, that had the plan name and their corresponding PBM and their standard plan partner. So that'll be there for reference for you as well.
Another question, do we need to contact all plans to get enrolled, or will this process be on the portal for enrollment to all the plans? So it sounds like the question is there one place to go and fill out an enrollment and that's for all plans, or does each individual plan have their own enrollment and a place to go for that?
Would one of the plans like to take that question?
Yeah, this is Jason. You're going to have to sign up with each individual plan. And again, as Angela stated, we have the contact information in the slide deck as to where you need to call or go to.
Okay, another question. Can we confirm if standard HP, prepaid HP, and Medicaid Direct are or are not the same for behavioral health providers?
Amy, I'm not sure I follow that question.
I think it's asking, and if the person who asked that, Michelle, would like to give us a little bit more information, I think it's asking, the standard plans are different from the tailored plans, even though some of them may have the same PBM for pharmacy. That was what I was thinking that it was asking. And then Medicaid Direct is different. That's the patients that we are retaining back in old Medicaid or regular Medicaid.
So the benefits are the same, but each plan may offer value-added services or special services above the base benefit. Would any of the plans like to add to that? And I'm not sure if we've understood the question fully.
Another question says, how does enrollment change for out-of-state pharmacies that service facilities?
So out-of-state pharmacies would need to be, first of all, enrolled with Medicaid as a North Carolina Medicaid provider. Would any of the plans like to speak to how you would handle an out-of-state provider that's enrolled with North Carolina Medicaid, but not necessarily your plan?
If they're out of state, initially we'll cover claims for the first 90 days. After that, they will need to be enrolled. Um, I don't think anyone else is handling it any differently.
This is Jay with Via. So yeah, I think it's important to differentiate between enrolling with Medicaid and contracting with the plan. So like Angela said, that enrollment is just one enrollment on NC Tracks as your pharmacy enrolling in North Carolina Medicaid. And then what Navitas, our PBM, is doing is they're using that list of all the enrolled pharmacies in North Carolina, or in North Carolina Medicaid. So if you're a pharmacy enrolled in North Carolina Medicaid, regardless of whether you're in our area in the state of North Carolina or outside of the state of North Carolina, we're going to be reaching out to every single one of those pharmacies and sort of extending that offer to contract. So if you're an out-of-state pharmacy, as long as you're enrolled in North Carolina Medicaid, you should be getting a contract offer, I guess, for Navitas for Via's pharmacy network.
Yeah, that's the same with Trillium.
And it's the same with East Point through Express Scripts.
The same for partners as well.
Okay, then the next question says, I work at an FQHC 340B center. Do you anticipate any changes with 340B?
No changes are anticipated with how 340B is billed to Medicaid or reimbursed by Medicaid.
Oh, yeah, or with the tailored plans.
It's consistent across all of our plans, actually. There are no differences in how 340B is managed.
So we are at 9:25 now. Should we move on to closing remarks?
Yes, we should, and we'll gather all the questions that were unanswered in the chat and provide answers back out to that, probably in the way of an FAQ document.
Angela, did you want to make any following remarks? I mean, I know Mike and I are sort of slated for that, but I also wanted to make sure I didn't give you or anybody else who've been such great panelists the opportunity to do that today.
Yeah, I'll just say we all share the common goal of ensuring that our beneficiaries receive their medications and the care they need on day one. You heard that consistently from us and from the plans, and we depend on you to help us make that happen, of course. It's a partnership. I hope that that's obvious to you. It's DHB, but it's the plans and it's you, pharmacies, and we will no doubt ensure North Carolinians who need us the most will experience seamless service going into this managed care launch, same as we did for the standard plans. And if you have any questions about anything you heard here today, please do not hesitate to reach out to us. And we just thank you so much for attending. Thank you, Plans, for sharing your time with us this morning and sharing details about your plans and your services and your contracting. Just know that at North Carolina Medicaid, we appreciate all that you do, each of you, for Medicaid beneficiaries on a daily basis, and especially during these transitions to managed care.
Angela, I'd just like to say on behalf of the pharmacy community, and Mike James is on here as well, we really appreciate all that you and your team did to put this together. When we came to Angela at first and said, could we do a webinar, because we think that will help get rid of a lot of confusion or help answer a lot of questions, she was really quick to say, yes, let's do that. And so we really want to say we appreciate it very much and thank you for all the time and effort your team put in it. But I also want to say thank you to the plans that came on, and they did a couple rough, dry runs on this, and have been stalwarts on trying to make sure that we got the information to people that they needed. And so we really appreciate all that the plan representatives did by committing their time to get this prepared and the remarks prepared and to come on and answer questions today. And so I just want to say thank you very much to everybody. And again, a great turnout this morning. Again, I think that shows the value of this program. So thank you.
Absolutely. Well, with that, we wish you all good health and a very productive day. And we will now close the webinar.
Thank you.
Thank you, everyone.